We know there are 4 pillars of therapy for heart failure, we just saw. With regards to MRAs and ARNI, very small proportion of patients tends to develop hyperkalemia when we put these patients on ARNI and MRAs. So what would be your strategy, sir? Should we reduce the dose and stop ARNI and MRA, or should we don't want to take this drug out of the prescription, you continue these drugs and add a potassium binder so that the patient derives the best benefit out of these drugs? Because there are few papers on patiromer and sodium zirconium glycosilicate. So these potassium binders are now, they seem to be safe. Do we put them on long-term potassium binders and just keep continuing ARNI and MRAs?
See, there are two issues here. I think one, the problem of hyperkalemia is more pronounced when the patient is clinically very stable. I think when you have patients on good dose of diuretics, a lot of time most of these patients tolerate a combination of MRA. When it becomes reasonably stable and we have the borderline renal dysfunction, that's a patient who tend to develop hyperkalemia. In my clinical practice, my preference is like I prefer ARNI over MRA. So I don't sacrifice ARNI for hyperkalemia. So I usually continue with ARNI. And if the patient develops a hyperkalemia, I tend to withdraw MRA. I think that is, I won't say it's a very, very small portion. I think I should say it's a significant proportion, maybe close to 20% of the patient on regular heart failure or treatment, we may not be able to continue with MRA because of hyperkalemia, one. Second, one thing good about this 4 combination is like SGLT inhibitors have shown to reduce potassium levels. Tendency to develop hyperkalemia is reduced when patients are started on SGLT inhibitors. That's what they say, when you start with SGLT inhibitors as a primary combination, the chances of hyperkalemia preventing add-on drugs is less than the regimen without SGLT inhibitors. So I'm not like very comfortable with long-term continuation of a patient with hyperkalemia with a potassium binding agent and a mineralocorticoid receptor antagonist. I would rather, I don't know, it's my personal experience and view, I would rather pull out MRA from the combination and continue with ARNI. I would like to hear from Dr. Abraham Moman also.
Same here, but only thing is up to 5 or 5.5 you can continue MRA. And ARNI plus, as showed in the slide, ARNI plus MRA had less hyperkalemia, potassium more than 6 than enalaprilat alone. Look for other causes which produces hyperkalemia, which includes painkillers, local treatments, Siddha medicines, etc., etc. If you, once it reaches more than 5, reduce the dose of MRA and C. Still, if it's more than 5.5, I would stop MRA. So there are 2 cutoff for potassium, 5 and 5.5. And at 5, I'd reduce. For 5 more than 5.5, stop. Still, if I say that patient is sick, I may, like Patromer has not yet come to our country, and we have Finerenone. Finerenone has not been studied in heart failure, but Finerenone non-steroidal MRA, what they have found is hyperkalemia is much lesser, and it reduces heart failure. The Fidelity, Figaro, all trials, the maximum benefit they got was prevention heart failure. So I would not be surprised in the future they would come with a specific heart failure trial. I put few patients on Finerenone whom I could not give MRA because of hyperkalemia. Hyperkalemia means not very severe, but 5.5, 5.6, I don't want to break the thing, and that is how it is. Be careful, look at other factors. But if you have all 4 on board, see, there is a thought process. If you have all 4 and if you have 3, what's the difference? Mortality differs. So in a way, if you're not giving all 4, you are doing harm to the patient. So rather than, so negative thinking, negative reverse engineering, you are very good. So if you should think that way, if you're not, all 4 are not on board, mortality increases. There's a study on that. So I would try my level best to have, I will change from spironolactone to eplerenone, still not, I would go to Finerenone, still, but more than 5.5 I would be very careful.
And one more question. With regards to SGLT2 inhibitors, many of the patients, especially female patients, they come back to us saying they have dysuria and features of UTI. So when we take that drug off, do you reinitiate, or what is the strategy, sir?
See, this is one real problem we see with SGLT inhibitors. I think I would say, like, I don't know about others. In my personal experience, is more than what is reported in the literature. I think close to clinical practice, close to around 10 to 15% of our patient report some urinary symptoms, and discontinuation has to be there for close to 10% of the patient for these symptoms. Maybe related to hygiene, or second, we are not educating them properly, or I don't know. Maybe another thing is we are not sure that sometimes we have a lot of generics on DAPA now. So sometimes I try to, when the patient has a urinary symptoms, after convincing the patient and educating them, I have done few changeover of drugs, maybe from DAPA to EMPA, or from a generic to a innovator brand. These are all I've tried, was successful in some 30-40%. But there are good number of patients whom you cannot continue, and patients are very negative about this side effect. I think they are not very comfortable with this, and they stop. If you don't stop, they stop. So that has happened to me around 10% of the time. I think I would like to hear from Dr. Abraham, sir.
Yeah, again, see, the SGLT2 inhibitors produce genital mycotic infections. UTIs, as we call, is not actually the problem with. So there have been some studies where they compared UTIs and SGLT2 inhibitors and like the statin nocebo effect. But whatever it is, somebody would tell that it's due to the drug. So like I would stop, but then I would reintroduce. Even SGLT2 inhibitors, what they have found is that reinfections are much less. So just because they got once does not mean that they will get another, and chance that they get reinfections are even lesser. That's one thing. Secondly, DPP, if you're diabetics, I would ask them to start taking DPP-4 inhibitors because they have been shown to reduce that. And I would try to convince them that many times I ask them, what I do is, have you had UTI before? And most of these patients, almost, because I had done this exercise, most of the patients, nearly all of them said they had UTI before. But it was never attributed to drug, it was attributed to diabetes. Then I tried to educate them, I stopped that and reintroduce, sometimes like many a times with the innovator molecule itself. And I got good success. Very few people, but that is ingrained in their mind. And another thing which I do is what is the HbA1c at that time. Again, what I found is nearly about the numbers Dr. Lawrence says is very reproducible. Mine is also about in the trials. I was part of many trials. In the trials, I was part of Emperor Preserved, Emperor Reduced, Credence. All of this we found very less because we are monitoring them very well. But the thing is, the people who had UTI, their sugars were quite high. So I tried to convince them, because heart failure is a bad disease. It is one of the worst diseases you can have.
Probably it can be due to this thing, because we have most of the patients on cardiac failure, we tell them to restrict the fluid. The fluid restriction also gives concentration of the urine, and at times, that also one of the triggering factor. It's not only for the females, for the men also. That can be attributed to this problem. Because we tell them to take less than 1 liter of water and other things.
Yeah, but this also was looked into. Bladder, urinary, the concentration of basically concentrated urine, or because of, but they found that this is specifically looked into, and they could not pinpoint it to this, because what happens is genital mycotic infection, it's not UTI. UTI numbers in the trials were extremely low. Even genital mycotic infections were low. But we tend to mix both together. But we can't, our patients invariably can't differentiate between the two. But if they have UTI or genital infection, I tend to stop. I try to reintroduce for everybody. And I've succeeded in most, except a few people, because they've been told that this drug produced that. Then I said, I will give another drug, but another brand or another of the class. And I got away successfully in that also. Because we have to be proactive in heart failure. Otherwise, they are going to die. If you see like 100 heart failure patients this year, you're going to see only 70 of them next year.
And one last question, sir. Few patients with idiopathic dilated cardiomyopathy, we put them on all these class 1 recommended drugs, and then over a period of time, when we follow them up, LV dimensions decrease, the LV ejection fraction improves, the patient never gets admitted for heart failure. and then it's now more than a year or two, and the patient asks if you can come down on the drugs. So should we still keep continuing all 4, or can we pull out MRA, or what should we do?
See, ideally the problem is, that's what the new class is now, heart failure with improved ejection fraction. So the patients who have started on all these heart failure foundational therapy, and they are doing well, and LVS normalized. Until unless, I think, you had a reversible reason for a LV dysfunction. Could be a patient had an intercurrent myocarditis and had an LV dysfunction, and that has improved. There is no reason for us to pull these drugs out. Maybe if any of your drug is creating trouble to you, maybe you can consider pulling out. Like maybe you are playing around with a potassium of 5.5 most of the time, and you are struggling to hold on to MRA for a long time. And when the patient improves, when your diuretics are off, again the potassium becomes a much bigger problem. And at that time, I may take out MRA out. By chance, if a patient with SGLT inhibitor is not tolerating the drug pretty well and had multiple issues with that drug, when the patient LV completely improves, I may take a freedom of taking it out. But otherwise, by guideline wise, the drugs to be on, because these are the drugs which have made this LV to this normal level. The same applied to CRT. When the CRT came, a lot of people have found that when the patient is on CRT, LV has become normal. When you switch off the CRT, LV worsens again. So these are all therapies which have brought the LV back by neurohormonal modulation. So when you withdraw this neurohormonal modulation, there's a high possibility that the patient will go back to LV dysfunction.
Can we reduce from 200 milligram BD to 100 milligram BD?
Sir.
Yeah, a difficult question to answer. There's a study called TREAD-HF which looked at patients, same thing. They stopped and they found that there was a recurrence of 51%. So if you stop, or it's very bad. Now the question is, can we reduce? Answer is nobody knows. But if they're tolerating on something, if they're tolerating well, continue. If they're not tolerating, individualize. Another thing is, another question, now that question is moot because ARNIs are very costly. They said, this I have done, because sometimes they said, I just cannot afford. What should I do? Sometimes I switch from ARNIs to AC inhibitors. Now that question is moot. One other thing which I look for is that global longitudinal strain. And majority of the people, even the EF is dependent on preload, afterload, heart rate. So EF is a very inaccurate measurement. So we know that HFpEF and HFrEF 5-year mortality is almost the same. Even in 200 heart failure registry, HFpEF 5-year mortality was 45%. So EF is not an absolute thing, but I also look at obviously reversible factors. Apart from that, the GLS, global longitudinal strain, and if they are still on the lower side, less than 15, I would not withdraw at all or reduce. If they are more, everything is fine, I may, when the pressures are borderline, I may think of coming down, but if the patient says I'm fine, I continue the same. If there is some reason, then I would but then I don't have any particular preferences of coming down because we do not know which one can be taken off. But that will be individual. Potassium is high, MRA out.
See, like in a cycle of a heart failure, I think you would also have seen the patients who had a normal LV sometime back, sometimes comes back again after 1 year or 2 years of good drugs, LV goes down, and you will see it's changing. So it's a very dynamic thing. I think it's like there are a lot of things which cause this LV dysfunction and heart failure to happen. I think if the patient is doing well with the drugs, I would always tell all my patients, like, if you withdraw, there is a possibility that you may go back to the previous level. And most of the people accept and understand. And there are patients who have stopped the drug and who come back with, again, 20% EF is not very uncommon. The fellow has EF was 60%. With drugs, suddenly comes back with 20%. And unfortunately, it has seen in CRT trial also, the second time you may not be lucky. There are people who improved well, stop the drugs, who come back and you restart the drug. A lot of times they don't do well as well as they did on the first time.
Is there any blood test to gauge the level of the drug in the bloodstream, the system, so that reduce the dose? To reduce the dose, as you said, maximum therapeutic dose. We don't have any facilities in India to estimate the level of the drug in the system.
You don't have to. You don't have to. Sir. You
Do
don't
you-
have to. Like, these are the drugs, you don't have to monitor the levels. So the thing is, see, these drugs have been tested on trials on a particular dose, and the dose is found to be effective. That's the reason all the guidelines recommend two things. One is you have to go with a guideline directed dose or maximum tolerated dose. Both are acceptable. There are some patients whom you may not be able to go on a 200 mg of ARNI, but if you are convinced as a physician that the dose at which you are continuing ARNI is the maximum dose tolerated by the patient, that's good enough. You don't have to monitor anything on this patient to see, because it's not like digoxin or anything where you need to continuously monitor the level of the drugs. Here what you try to do is, you try to achieve a particular dose which has been tested in the trials to provide benefit, or go as close as possible, as much as patient can tolerate. This should be the target of you in heart failure management. You don't have to stick on, like, there are a lot of people like feel like the 200 dose is not possible at all. Like, I would say in my clinical experience, like, there are close to around 30% of my patients on heart failure who are on 200 mg of ARNI. So it's not very uncommon for you to uptitrate if you are consciously watching and uptitrating. And definitely the people who take higher doses, trials have shown that they do better. So your primary aim should be to reach that dose as much as possible in a patient without affecting the hemodynamics.
Hearty congratulations on conducting the 7th Kovai Heart Rhythm Summit, sir.
Yes.
It's very nice to go through all the sessions and with renowned speakers. My question is, we get a lot of references from gynecologists, obstetricians to assess the heart for IVF therapy. Is there any particular reason, sir?
I see that, I don't know, like, one reason why, which I know, was some issue which happened some time back in some private hospital where they could diagnose a LV dysfunction during a delivery time, and it was a pre-existing LV dysfunction which patient relatives are not ready to accept. So now most of the gynecologists have become little anxious, and most of the patients, not only the IVF, a lot of patients with a normal pregnancy also get a LV function done. Maybe that's the one reason. I think otherwise I don't see any reason why we have to do. That's not recommended basically. You don't have to assess LV function for all the pregnant patients, not the recommendation.
What drugs do you suggest for any sort of heart failure in pregnancy, sir?
Right now the one drug which has been tested and supposed to be safe is beta blocker. You don't have anything against beta blocker in pregnancy. Particularly metoprolol has been shown to be very safe, because as an antiarrhythmic we have used metoprolol for a long time on pregnant patients. We never had any trouble with metoprolol. Other drugs have problem. So in a pregnant patient with heart failure, I usually continue with beta blocker and diuretics as much as required. And once they, in a postpartum period, bring back all the drugs which are used for heart failure management. Sir, your take on pregnant
Same
patient.
thing, because I showed a slide. SGLT2 inhibitors, MRAs and ARNIs are contraindicated. So partly it's not been used, but because nobody's, SGLT2 they tried in pregnant rats, etc. They didn't find anything abnormal, but it has been contraindicated in trials, so as of now it is contraindicated. Beta blockers, diuretics, that's the only thing as of now we have. So that's how it is. And IVF thing, if many of these IVF ladies are older, if they have diabetes, hypertension, so guidelines mandate, or at least in the position statement and the mandate, that they look for heart failure in such patients. So if they are diabetic, many of them we see diabetic, obese, hypertensive. So as a part of diabetes or the stage A evaluation, nothing wrong, and it's a cheap investigation, so that we will have much more information and avoid pitfalls. So that's what I do. If if they ask me, I'd say, okay, do a baseline echo. So suppose some 25-year-old girl, but they wants an IVF for some reason, everything normal, I would just clear that.
Thank you very much.
Before concluding, I just want the CRT. You are doing CRT only for patients who have got M.B.B. with heart failure. Is there any study with RBB and heart failure, or people without M.B.B. but severe heart failure? Any studies actually indicating us trials with CRT?
See, CRT heart failure, as I told you, they don't specify your morphology. Basically, the morphology is for the class of recommendation. LBB white QRS 150 milliseconds is a class 1 for CRT. So, if you have a non-LBB pattern, if it is more than 150 milliseconds, if the patient is class 3-4, is again a class 1 indication. So, the LBB they do better, but any patient who has a white QRS heart failure, CRT is indicated. That's the recommendation right now. Only place in heart failure where CRT is not recommended is narrow QRS. If you have a heart failure with QRS with 120 or less, CRT is contraindicated. More than 120, the class of recommendation changes. Class 1 to 2A to 2B, there will be change in recommendation. But all patients with a QRS with more than 120 milliseconds and heart failure, in spite of guideline-directed medical therapy, they are candidates for CRT.
And I think usage of optimal usage of beta blockers and diuretic, we are actually using very low dosage actually comparatively. In Western countries, they go up to 40 milligrams of bisoprolol, whereas I hardly exceed 10 milligram of bisoprolol. And again, diuretics, we are very stingy. Actually, Europe and all, 400 milligram tablet furosemide, Lasix tablet, 400 milligrams. One of my friends actually came last year. He is actually post-mitral replacement failure patient. He was actually taking 400 milligrams of one tablet, Lasix, prescribed in UK. He told here no 400 milligrams tablet is available, Ramakrishna, what to do? Then he told me here even 100 milligrams our people are not able to tolerate. Maximum is 100 milligrams. Then he could not get 100. Then he used to take 10 tablets of 40 milligrams tablet every day. We have never heard, 400 milligrams of Lasix every day. Actually, beyond my imagination. But we are our usage of diuretics and beta blockers compared to the Western population is less than 50%, I can say. Maximum, what is the dose of bisoprolol or something you have used to this thing?
Recommended dose of beta blocker, maximal dose is 10 mg. So, most of the patients with heart failure, until unless it's bradycardia, I usually step up on 10 mg is a very common dose for my patients. And fortunately, if there a patient has a device, then 10 mg is very easily manageable. Only problem I see with bisoprolol as a beta blocker is bradycardia, significant bradycardia compared to other beta blockers also. So the patients on devices, they tolerate 10 mg very easily, and maybe around, I would say that close to 40% of my patients would have reached full dose of bisoprolol.
Still that is compared to Western population where they go metoprolol up to 400, 450 milligrams. And for 40 milligrams of bisoprolol, which actually nobody and nowhere in India, we are not there enough to write such dosages. Anyway, our patients are comfortable with whatever we write.
No, that as I told you, that guidelines clearly say that you have to give them a maximal tolerated dose of drug. So that means that if your patient is able to tolerate 2.5 mg of bisoprolol, and you have given him a 2.5 mg of bisoprolol, and you are carefully watching and uptitrating, you have done a justice to the management. You don't have to be worried that I have not reached 10 mg. If your patient tolerates only 2.5, if you have reached 2.5, that's good enough.
Any questions from the floor?
To qualify this thing, Lawrence, our population have got needs only lower dose when compared to that international study, isn't it? We don't go by that.
Not exactly. I would say, like, if you are very careful enough, that's what I told you. Like, when we are discussing about ARNI, the most common statement comes across is none of our patient tolerates even 100 mg. I told you 30% of my patient have on 200 mg of ARNI. So it's like how closely you are monitoring and your willingness to uptitrate. So if you are closely monitoring them and uptitrating, you may be able to reach good doses even on our patients. And again, second statement, as I told you, if you are not able to uptitrate to the level which is recommended in the guideline, but you have reached a maximum tolerated dose, that itself is good enough.
Just few comments. Yeah, the dose, the beta blockers, metoprolol recommended dose is 100-200. So it is not that easy to reach that doses. But if the patient is tolerating and still if you can go up, but bisoprolol dose is 10. So bisoprolol is the easiest drug to reach the guideline recommended dose. So that's why one of the reasons why I like bisoprolol, except for bradycardia, it's very well tolerated. Somebody's blood pressure is on the higher side, I go the carvedilol 50 BD. The dosage of carvedilol is 25 to 50 milligram twice daily. It's if the patient's BP is on the borderline, it's very difficult to reach that stage. So individualize the patient, go up. Easiest to reach the GDMT is bisoprolol. And the point is, if you do not strive to, we cannot, like 50% of them, I've got now nearly 500 patients, even more, on 200 BD of ARNI. And it takes time. I don't rapidly titrate over a month, but they can take it and they show it has got benefit, because it has been shown that people taking 200 BD has better response than somebody who has to be down titrated. So lower dose works, low dose is better than no dose, but right dose is better than low dose. That is how I approach that. Another thing about the IVF, because there was a discussion about ovarian hyperstimulation syndrome, that's not during IVF therapy, patient can come like heart failure. They would not have heart failure. They will come with fluid overload kind of picture, bloated abdomen, swelling, and you have to differentiate between heart failure and ovarian hyperstimulation syndrome.
Thank you, sir. Any questions from the floor before we conclude?